Good morning, everybody. It is such a pleasure to welcome you all to our PE Grand Rounds this morning. We have quite the treat this morning and some phenomenal speakers. Before we get to that, though, I wanted to take a moment to really wish our hospitalist colleagues a very, very happy hospitalist day, which was yesterday, the first Thursday of March every year. Really thank you from the bottom of our hearts for everything you do for our patients, our teams, our communities, and your dedication, expertise, and unwavering commitment. So we really, really appreciate all of you. So thank you. With that, please stop sharing. Okay. It is my pleasure and my honor to introduce our speakers for today. It's quite a group of folks who have expertise that are coming together to really give us an update on how should we be thinking of type 2 diabetes management. So first up, we have Dr. Pothuloori, who is a general endocrinologist presently serving as the program director for the Endocrinology Fellowship at Creighton University Medical Center in Omaha, Nebraska. Dr. Pothuloori completed his endocrine fellowship training at Dartmouth in New Hampshire. He was in private practice in Kansas City for 6 years prior to joining Creighton University and has served as the chair of the Patient Voice Committee for Endocrine Society and is a panel member for the Endocrine Society's Clinical Practice Guidelines Committee. So something a lot of us are very familiar with. Dr. Mandeep Bajaj is the Vice Chair for Clinical Affairs within the Department of Medicine and a Professor of Medicine and Molecular and Cellular Biology at the Baylor College of Medicine in Houston. He is the Chief of the Section of Endocrinology at Baylor St. Luke's Medical Center, as well as the Medical Director of the Baylor St. Luke's Medical Center Diabetes Program and Baylor Medicine Endocrinology and Diabetes. Dr. Bajaj is a very well-known and reputable clinical and translational researcher in obesity and type 2 diabetes with over 100 publications and has been the past president for medicine and science of the American Diabetes Association and currently serves on the ADA Board of Directors. He has many more accolades, but for our purposes today, we're really excited to bring him on board to share his expertise as well. And of course, we have Debra Rockman, who is the System Vice President of Ambulatory Quality for CommonSpirit Health, registered nurse with 39 years of experience in clinical, educational, quality, and risk aspects of the healthcare industry. Debra received a Bachelor's of Science degree in nursing from the University of Texas Medical Branch and Master's in Business Administration from Texas Women's University. She's a member of the American Society of Healthcare Risk Management, National Association for Healthcare Quality, and designated as a certified professional healthcare risk management and quality. And for all of us who have the pleasure of working with Debra, she is a powerhouse of quality improvement, patient safety, and we could not do all the things we do without her partnership in Ambulatory. So thanks, Debra. With that, I will hand it off to our first speaker, and I will also make a plug. Please keep your questions coming in the chat because we will answer them.
All right. Thank you so much for having me, and I look forward to giving you guys a brief update on the current standards of care and management of type 2 diabetes with SGLT2 inhibitors and GLP-1 and GLP-1 GIP receptor agonists. Okay. So my objectives today are just kind of review the current standards of care for SGLT2 inhibitors, as well as for these GLP-1 GIP receptor agonists. And we'll also briefly go over some current clinical trials and research. I have nothing to disclose. So, one of the most common questions a lot of providers ask me is, how do we choose? How do we figure out where do we start with these medications when we get a new type 2 diabetic patient? And I always tell them that one of the most important things, or the baseline of diabetes treatment, really is to address the underlying lifestyle issues with a patient. Are they exercising? Do they have underlying depression? Do they have diabetes distress? And also dietary changes. I always try to get a very detailed dietary history from the patients, and then I get them involved with my dietary team. So that should really be the foundation of management of type 2 diabetes. But yes, of course, the medications play a very important role in management. For most patients with type 2 diabetes, we can start with metformin. It's a very safe treatment. It has a lot of beneficial effects, a lot of protective effects. And then as I go through my decisions in this huge plethora of medications that we have over the last 5 to 10 years, I look at their complication risk. So, for example, if they have heart failure or high risk of heart failure, the current research and data would say that we should put them on an SGLT2 inhibitor. If they have chronic kidney disease, initially we used to say, oh, SGLT2 inhibitors were the main treatment, but we're learning in more recent clinical trials that even the GLP-1 agonists or GLP-1 GIP receptor agonists can have some benefit in this realm of care. When I look at patients with a high risk or with atherosclerotic coronary vascular disease, a GLP-1 receptor agonist or SGLT2 is very beneficial in this situation. You'll see a common theme here. The common theme is that the GLP-1s and the SGLT2s seem to have multiple benefits, but we have to individualize care. That's very important. Certainly in the realm of obesity, our GLP-1 medications are very effective, and they've seemed to have other effects in terms of fatty liver disease, which Dr. Bajaj will discuss. Now, let's say someone does not have any known complications. Well, this is where we do individualized shared decision making. For example, if the patient tells me, Doc, I feel hungry all the time and I can't lose weight, then I might be more inclined to start them on a GLP-1 receptor agonist, which has the benefit of appetite suppression and weight loss. But we individualize care. Remember, most important, address the human being behind the disease, their lifestyle, their dietary choices, any underlying depression, and then we go from there. So let's take a closer look at our SGLT2 inhibitors. The current recommendations on use of SGLT2 inhibitors and the ADA standards of care, they were updated in 2025 again, American Diabetes Association Standards of Care, and this is very important. It says specifically, adults with type 2 diabetes and CKD with a confirmed eGFR of 20 to 60 and an SGLT2 inhibitor or GLP-1 receptor agonist with demonstrated benefit in this population should be used for both glycemic management, irrespective of A1C, and for slowing progression of CKD and reduction in cardiovascular events. Keeping in mind that the glycemic benefit of SGLT2 inhibitors is reduced at a GFR of less than 45. But this is very important. There's significant data that shows that these medications can slow down progression of CKD. Now, the American Heart Association has a significant interest in SGLT2 inhibitors as well, specifically in the realm of heart failure. And their studies have shown that these medications also reduce hospitalization for heart failure and progression of heart failure. Their main recommendation, do not delay therapy. And American Diabetes Association, as you'll see in our next slide, has also emphasized this point. It is recommended that we should screen for asymptomatic heart failure and type 2 diabetes. Individuals with diabetes are particularly at a higher risk of progression of asymptomatic stage A to stage B heart failure and stage C to stage D heart failure. And based on this evidence, we should consider screening our asymptomatic adults with diabetes for development of structural or functional abnormalities. And one recommendation that is in the current American Diabetes Association Standards of Care is to check a BNP, and a value that is greater than or equal to 50 would warrant further workup, or a pro-BNP greater than or equal to 125 would warrant a further workup. Now, there are numerous studies that show benefit of SGLT2 inhibitors in atherosclerotic coronary vascular disease. We'll go through some of these studies in the upcoming slides. But there's something to keep in mind. I apologize you can't see the top part of this slide, but these medications are not without risks. And so even though we have all these indications in preventing complications, we have to individualize care and make sure that these patients aren't put at risk for further complications. SGLT2 inhibitors are associated with a complication known as euglycemic DKA or diabetic ketoacidosis. The risk factors for this are higher risk in people who are put on these treatments as a type 1 diabetic, dehydration, alcohol use, prolonged fasting, low carb diet. So these are things to keep in mind when you're treating your patients individually. Another thing I might add before we go on to this next section is that SGLT2 inhibitors can contribute to orthostatic hypotension. So if you have a elderly patient with osteoporosis, high risk of falls, you might be a little bit careful in that patient population. Now let's take a brief look into GLP-1 agonists, the GLP-1 and GIP agonists, or glucagon-like peptide agonists, or glucagon-like peptide 1 and gastric inhibitory peptide agonists. We have quite a few in the market now. Mounjaro, Trulicity, Ozempic, Byetta, Victoza. So how do we choose? Let's take a look at the data. First of all, in general, these medications have many effects, and we're actually learning that they have even more effects than we previously thought on diabetes and other complications of diabetes. But in general, they have demonstrated effect in reducing cardiovascular mortality, improvement in kidney outcomes. We'll talk about the FLOW trial. And there's even a large amount of data and studies looking into metabolic associated steatohepatitis and it's addressing visceral fat and the complications of excess visceral fat. The GLP-1s historically were thought to be given to just to patients who have obesity, and they have quite a few beneficial effects, and this really helps guide treatment. For example, these medications in the brain will decrease the appetite, they decrease food cravings. So in patients who seem to have hyperphagia or a constant craving of carbohydrates, these medications are excellent for those patients. In the pancreas, these medications increase beta cell function and glucose-dependent insulin secretion. So what does that mean? Well, if you look at medications such as glimepiride or glipizide, those result in continuous insulin release as long as the medication is in your system. But when you ingest carbohydrates, the insulin secretion is based on the amount that you're ingesting. It's very dependent on the amount of glucose, and therefore it's not continuous. It's a certain amount. And then this also helps suppress glucagon, which is the hormone that tells your liver to kind of pump out sugar when you're not eating. So this has multiple effects. It does stimulate the vagus nerve, which can contribute to delaying gastric emptying, but that effect seems to wear off after about 4 weeks. And with the gastric inhibitory peptide added to a GLP-1, as seen with Mounjaro, we seem to see a less of the side effect compared to, say, our GLP-1s alone. The GLP-1s have had multiple studies going on. There's benefits and reduction major adverse cardiovascular events. There seems now new studies showing that there's benefit in decline in progression of chronic kidney disease. So let's take a look at some of these trials. Well, look at this. How exciting is this? Obstructive sleep apnea. Who would have thought? But tirzepatide or Mounjaro has been studied in what's called the SURMOUNT obstructive sleep apnea study. And it has shown benefit in improvement of obstructive sleep apnea. The FLOW trial has studied semaglutide, and it showed that there's a reduced risk of sustained eGFR decline and reduced risk of progression to end-stage renal disease. Okay. And if we can, we'll talk a little bit about some of the clinical trials, but what I wanted to highlight on this slide is that this is a summary of the SGLT2 pivotal studies with cardiovascular and renal endpoints in patients with type 2 diabetes. And most of these did show a beneficial effect, statistically significant effect in reduction in the primary outcomes. So empagliflozin or EMPA-REG trial had to do with Jardiance. The Canvas trial had to do with canagliflozin, and Creighton's trial as well had to do with canagliflozin, and Declare-TIMI trial had to do with dapagliflozin. What we're seeing in general is that these medications as a class are beneficial, not only in chronic kidney disease, but also in reduction of major adverse cardiovascular events, reduction for hospitalization for heart failure. The DELIVER trial is a trial that was recently done, 2022. It looked at dapagliflozin in heart failure and with mildly reduced or preserved ejection fraction and without um, the conclusion of this trial was actually quite significant. We go to the next slide. The conclusion showed that dapagliflozin reduced the combined risk of worsening heart failure or cardiovascular death among patients with heart failure and mildly reduced or preserved ejection fraction. So it looks like this one, in addition to some of the other SGLT2s, does have a benefit. How about the Emperor Preserve trial? They also studied empagliflozin in heart failure preserved ejection fraction. And if we look at the conclusion without surprise, then you will see that, as on the next slide, the conclusion shows that empagliflozin reduced the combined risk of cardiovascular death or hospitalization for heart failure in patients with heart failure and preserved ejection fraction, regardless of the presence or absence of diabetes. This is actually quite interesting data that came from this trial. The FLOW trial is one of the first studies that looked at the effect of GLP-1 medications on CKD, specifically at semaglutide or Ozempic. And surprisingly, well, not so much surprisingly, the conclusion showed that there, in fact, was a benefit. Semaglutide reduced the risk of clinically important kidney outcomes and death from cardiovascular causes in patients with type 2 diabetes and chronic kidney disease. So far what we've seen is quite a benefit of these treatments. And I'm quickly going to go through these next few slides, but they show that tirzepatide in the SURPASS trials at the max dose actually had decreased the prevalence of metabolic syndrome at the primary endpoint. This is very important. And compared to how about the other GLP-1 medications, most of them, these specifically were superior to placebo on cardiovascular death, MI, or stroke. And this is abiglutide, dulaglutide, or Trulicity, liraglutide, or Victoza, and semaglutide in the SUSTAIN-6 and PIONEER trials. The two GLP-1s that were non-inferior to placebo in terms of cardiovascular benefit were lixenatide and exenatide. So what about tirzepatide and cardiovascular outcomes? You know, we suspect that tirzepatide will certainly have a similar effect as the GLP-1 cousins in its group, but the SUMMIT trial was looking at a primary endpoint of fewer worsening heart failure events in the tirzepatide group versus placebo, with no difference in cardiovascular death. And with no surprise, tirzepatide reduced the risk of cardiovascular death or worsening heart failure and improved the health status in patients with preserved heart failure and obesity. So in summary, we are seeing increasing evidence of benefit of GLP-1 agonists, GLP-1 GIP agonists, and SGLT2 inhibitors in the following areas: reduction in progression of chronic kidney disease, recurrence of atherosclerotic coronary artery disease and type 2 diabetes, reduction in hospitalization and all-cause mortality for heart failure. But there's also many upcoming trials on effects on metabolic-associated liver disease. But there are benefits outside of diabetes. This has been one of the most exciting parts about these treatments, that we develop a treatment for diabetes and learn that it has effects on many other organ systems and conditions. We always have to remember, and I always emphasize, individualized care. Make sure you treat the patient first. Always remember lifestyle changes, dietary changes, and I would add behavioral health. It is very important to address behavioral health. Diabetics can get burned out from their diseases, and they may need assistance from time and time again throughout the course of their disease. Addressing depression is important. Metformin as a treatment option, and then look at their complication risk or current complications and treat accordingly. Thank you so much for having me, and I appreciate it.
Well, thank you so much, Dr. Pothuloori. That was wonderful and quite the summary of a lot of material. Dr. Bajaj, I'm going to hand this off to you directly, and we will move on and do Q&A after.
Okay, thank you. Let's start with managing metabolic dysfunction associated steatotic liver disease and type 2 diabetes. I have no disclosures. So let's start with a case. This is a patient, a 60-year-old with type 2 diabetes, referred to our clinic, is not known to have atherosclerotic cardiovascular disease or heart failure, does not drink alcohol, does not smoke. A1C is 8.9%, fasting glucose 187, mildly elevated liver enzymes, transaminitis, AST42, ALT49, platelet count of 130,000, LDL cholesterol 59, serum triglycerides 120. The primary care physician, given the transaminitis, screened for Hep B, Hep C. It was negative, ordered ultrasound of his liver, which showed hepatic steatosis, no gallstones. He's currently on metformin, 1,000 milligrams twice a day, and a statin. So he was advised weight reduction, and a referral to a nutritionist had been placed. What is your next step? Check a FIB4 score, order liver elastography if FIB4 more than 1.3, consider adding pioglitazone, consider adding a GLP-1 receptor agonist, or all of the above. And I'll come to this question in the end, so note down your answer and we'll go through it. So in type 2 diabetes and obesity, the essential problem is there's excessive adipose tissue, which produces a host of cytokines, as well as free fatty acids that go to the liver and stimulate de novo lipogenesis or lipogenesis within the liver, leads to hepatic fat accumulation, followed by inflammation, fibrosis, and then a cirrhotic liver. In addition, this de novo lipogenesis stimulates VLDL secretion from the liver, increased LDL cholesterol, ApoB, triglycerides, and increased risk of cardiovascular disease. So the major causes of morbidity and mortality are liver cirrhosis and cardiovascular mortality. Now, when we look at NASH, or what is now called MASH, or metabolic dysfunction associated steatohepatitis, the increasing fibrosis stage is associated with the increased risk of liver-related complications and death. And this is especially so at F3 fibrosis and the cirrhotic stage, or F4 fibrosis, as compared to F0 or no fibrosis, or mild to moderate fibrosis, F1, F2. And this includes an increased risk of variceal bleeds, ascites, encephalopathy, and most importantly, hepatocellular cancer, as well as death. So how do we determine the stage of fibrosis? Sure, you could biopsy the liver, but you could also do ultrasound with liver elastography, what is called now a fibroscan or transient elastography, and a measure of 8.2 or more, or roughly 8 or more, suggests F2 fibrosis or greater than F2 fibrosis, and patients with type 2 diabetes who have greater than or equal to F2 fibrosis have a greater risk of cirrhosis with liver decompensation, hepatocellular cancer, need for liver transplant, and all-cause mortality. This study was done almost 20 years ago when we looked at for the first time the effect of pioglitazone on liver fat measured by MR spectroscopy, magnetic resonance spectroscopy, in patients with type 2 diabetes. And as you can see here, treatment with pioglitazone reduced liver fat almost 50% and was associated with the increase in adiponectin. Adiponectin is an insulin sensitizing cytokine produced by the fat cells. It is low in those with increased liver fat and type 2 diabetes, and the value goes up after pioglitazone treatment. Adiponectin also increases fat oxidation in the liver and reduces liver fat so that you can see a nice inverse correlation between plasma adiponectin and liver fat before and after treatment. In addition, we showed that the liver fat correlates with the liver insulin sensitivity during an insulin clamp. So the more liver fat a patient has, the more hepatic insulin resistance, as shown in this particular study. And pioglitazone reduces the liver fat and improves hepatic insulin sensitivity. So these early studies then laid the foundation for looking at pioglitazone in non-alcoholic steatohepatitis and prediabetes in patients with prediabetes or type 2 diabetes. The primary outcome was a greater than 2-point reduction in NASH score without worsening of fibrosis, and this was significant. Whereas the secondary outcome, which included resolution of NASH, was also significant. A 1-point improvement in fibrosis, although showed a trend towards improvement, did not reach significance. And this study was published by Dr. Kuzi and his associates almost 8 or 9 years ago. We looked at the effect of combined GLP-1 and pioglitazone treatment on liver fat. The previous study was associated with weight gain as well as fluid retention, which is one of the problems of pioglitazone treatment. So that pioglitazone alone, when used for type 2 diabetes, reduces liver fat, but is associated with almost a 3.5 kilo weight gain over 12 months. But when we combine the pio with exenatide, a GLP-1 receptor agonist, the weight gain was ameliorated and the reduction in liver fat was significantly greater, close to about 60%. And it also was associated with a greater increase in plasma adiponectin levels. Today, as Dr. Pothuloori pointed out, most of the patients are on semaglutide and tirzepatide. So do we have any data with semaglutide and tirzepatide in NASH? So this is the phase 2 study with semaglutide in NASH, showing that in patients with F2, F3 fibrosis treated with semaglutide, 0.1, 0.2, or 0.4 milligram daily, you have resolution of NASH with no worsening of liver fibrosis. On the other hand, the improvement of one-stage liver fibrosis with no worsening of NASH did not reach significance in this phase 2 trial. But the phase 3 study, which was recently presented at the liver meetings, showed that in patients with biopsy-proven NASH and F2, F3 fibrosis, 2.4 milligrams semaglutide once weekly over 72 weeks was associated with both a resolution of NASH with no worsening of fibrosis, as well as a 1 point reduction in liver fibrosis with no worsening of steatohepatitis, both reached significance. Now, what about tirzepatide? Tirzepatide has been studied so far in a phase 2 study, which took patients with biopsy-proven NASH F2, F3 fibrosis, treated them for 52 weeks with tirzepatide 5, 10, and 15 milligrams versus placebo, and showed that there was resolution of MASH with no worsening of fibrosis, both at all 3 doses, 5 milligram, 10 milligram, and 15 milligrams. However, there was a 1 point reduction in fibrosis that did not reach statistical significance. So clearly, the primary endpoint, which was resolution of NASH with no worsening of fibrosis, was met. Their side effects were nausea, diarrhea, and constipation, as you see with these drugs. What about thyroid hormone beta agonists, resmetirom, which has recently been approved for the treatment of NASH? Now, in patients with non-alcoholic fatty liver disease, it is believed that it is a state of intrahepatic hypothyroidism, where T4 does not get converted to active T3, instead gets converted to the inactive metabolite, reverse T3. And you can treat with levothyroxine, but that does not improve this deficiency. All the T4 gets converted to reverse T3. So resmetirom is a liver-directed, orally active agonist of thyroid hormone receptor beta that is 28 times more selective than T3 for thyroid hormone receptor beta versus thyroid hormone receptor alpha. It has poor tissue penetration outside the liver and specific uptake into the liver. And in patients with NASH, this may provide metabolic benefits of thyroid hormone in the liver while avoiding the unwanted side effects of excess thyroid hormone on the heart and bone that are largely mediated through thyroid hormone receptor alpha. And resmetirom phase 3 results were published last year, showing that treatment with resmetirom in the phase 3 study was associated with NASH resolution with no worsening of fibrosis, as well as a 1 point or more improvement in the stage of fibrosis with no worsening of NAFLD activity score. So both the resolution of NASH and the 1 point improvement in fibrosis were statistically significant, as shown in this study. The commonest side effects were diarrhea, nausea that were seen in these patients who were treated with resmetirom 80 milligrams or 100 milligrams. So what does the American Diabetes Association recommend for the management of patients with non-alcoholic fatty liver disease? The groups with the highest risk of future cirrhosis, type 2 diabetes, prediabetes, or obesity with 1 or more cardiovascular risk factors, when they walk into your clinic, you measure the FIB-4 score based on AST, ALT, age, and platelet count. And there's an online calculator available. All you have to do is put in the numbers. If the FIB-4 score is 1.3 or more, then they have a higher risk of future cirrhosis. You get a liver elastography. If the liver elastography is 8 or more, these need to be managed by the liver specialist or gastroenterologist. If it is less than 8, then they can be managed by the primary care team. You've got to work on lifestyle modification, weight loss, and repeat FIB-4 every 1 to 2 years. If the FIB-4 is less than 1.3, then again, there's a lower risk of future cirrhosis and can be managed by the primary care team with a repeat FIB-4 every 1 to 2 years. Now, in patients with non-alcoholic fatty liver disease or MASL, you need to target obesity. And the ADA recommends those with F0, F1 fibrosis prefer a GLP-1 receptor agonist or a dual agonist, which is tirzepatide. Treat the diabetes, again, prefer a GLP-1 receptor agonist, dual agonist, or pioglitazone or a SGLT2 inhibitor, which in early studies have been shown to have some benefit in NASH. We simply don't have a phase 2 trial. And no specific MASH pharmacotherapy is indicated. Of course, this is in addition to lifestyle modification, weight loss, diabetes management, cardiovascular risk reduction, and need for metabolic surgery as based on the guidelines. Now, in terms of F2, F3 fibrosis, the ADA recommends using resmetirom as pharmacotherapy in these patients, in addition to obesity pharmacotherapy and diabetes pharmacotherapy. Once they have cirrhosis, then again, you could use GLP-1 receptor agonists and manage the diabetes with GLP-1s, but they have really not been shown to be of benefit, as our own study showed a few months ago, published in JAMA, that once there's cirrhosis, they do not prevent liver adverse events. And avoid resmetirom in compensated cirrhosis. It should be restricted to your use in F2, F3 fibrosis. And in decompensated cirrhosis, your only way you can manage the diabetes is use insulin. So the ADA logarithm that was just published, and Dr. Pothuloori went through cardiovascular risk, heart failure, etc., says mitigating the risk of MASH or MASL, use agents for diabetes therapy, hyperglycemia, with potential benefits in MASL or MASH, which is GLP-1 receptor agonist, dual agonist, pioglitazone, or combined pioglitazone GLP-1s, and use insulin in a setting of decompensated cirrhosis. So coming back to our patient, we can see this patient needed to have the FIB-4 score checked, order a fibroscan based on the guidelines if FIB-4 greater or equal to 1.3, consider adding pioglitazone, consider adding a GLP-1 receptor agonist, probably both, since the A1C is 8.9, and all of the above is the correct answer. So I'll stop here and hand it over.
Great. Thank you, Dr. Bajaj. I appreciate that. And I think as we think about our panel discussion, which we'll come to in just a minute, I want to introduce Debra into the conversation, because Debra, I know that you have led this enormous work behind improving diabetes. So I welcome you to share a little bit about that, just to give us context of where we're practicing.
Well, thank you. And thank you so much, doctors. That was so enlightening and educational for me. It just kind of dusted off the cobwebs for me. I've been a little removed from the clinical setting, but thank you for that. I have, as you mentioned, Dr. Sagar, have had the honor to lead our national initiative here at CommonSpirit Health around improving diabetes care across our primary care clinics. And when we came together as a healthcare system in 2019, shortly after formation, we discovered that over 20,000 of our patients that had a diagnosis of diabetes in our primary care settings had poorly controlled A1Cs. And when I say poorly controlled, I'm saying greater than 9. So significant lack of control there. And as a result, we embarked on a long-term journey to transform diabetes management in our clinic settings. Today, I'm just going to provide, and I'm going to share my screen here, a high-level overview of our approach to that work, really give you celebrate and review our achievement over the past several years, and then delve into our next strategic priority, which is really to assure equitable care across all patient groups when it comes to diabetes care. So let me share here. Okay, so first I'd like to just start with a quote from my dyad partner. And unfortunately, Dr. Greenswag was not able to attend today, but I'm sure he'll be listening to this recording. Many of you have heard this before. At the heart of why we do this work is because it's simply the right thing to do for our patients and their loved ones. Our commitment is to reduce downstream comorbidities so that they can experience more independence, life cycle events, birthdays, and celebrations. And, you know, this quote or some iteration of this really served as a call to action for our clinic teams. And it was kind of the beating drum over the past several years because we started each meeting or ended each meeting really just anchoring to these words and making sure it's not about just the metrics or the numbers, but it's the people that are entrusting us with their care when it comes to chronic disease care. So thank you, Gary, for your support. And thank you all who adhered to this mantra. So first off, I wanted to just review our approach, and we did have a structured approach for a change management model, but I really want to focus on 4 pillars today. First of all, we started when we formed as CommonSpirit very quickly after we set up and established a physician enterprise ambulatory quality council. And that council really served as our guiding body and informed our strategic approach and planning for really deploying and implementing all of the strategies that go along with health system change. We also set up an ambulatory quality collaborative, which was a learning collaborative where we brought together, and we still do, all of our teams, our champions, our provider leaders from across the enterprise to not only review performance, but share innovative best practices, highlight market bright spots, and really serve as a learning opportunity that has helped really kind of motivate folks and help spread change across this very complex enterprise. The other thing that we did with the diabetes and hypertension initiatives is we enlisted a powerful coalition and volunteer army. When you think about change, change requires buy-in, engagement, participation. And what we did is we built this strong network of provider leaders, clinic champions, quality support staff. And these individuals were really the engine behind the work. Many of you are on this call now because I looked through the participant list, and just thank you for that. But I got to tell you that without their compassion and their commitment, we could not have realized the achievements that we have. The next thing we did is variation reduction and standardization. We have a very comprehensive system of support for our initiatives, and specifically our diabetes initiative. We used evidence-based guidelines and protocols, designed a toolkit with standardized clinic workflows, guidelines. We have patient supporting resources that are engaging patients and setting treatment goals and monitoring and actively managing their diabetes, all in the name of supporting optimal and consistent care across our clinic settings. And finally, measurement and feedback. Our national clinical quality scorecard has been optimized year over year and has really been able to provide insight and visualization into performance, not only at the national level and regional level, but it has provided insight into performance at the provider and clinic level, which was really key during our entire journey, because what that enabled us to do is identify those clinic teams that needed additional support. We were able to actively engage with those teams, share what we've learned from more successful practice sites, and we're able to really support folks at the elbow support throughout our initiative. And as you can see, here's the impact of our strategy. We started out at 22% poorly controlled diabetes rate. That's the A1C greater than 9. And year over year, even during the pandemic, we were able to sustain that downward trend. And right now we're holding right at 13% for fiscal year to date. Just phenomenal, inspiring progress. Again, not only a testament to a structured change management approach, but also a testament to the dedication of our teams and engagement in this journey. Over the past 2 years, we've actually been able to stratify our data across demographic groups, and we realize that our work is not done. We've got a high level of overall success, but we do see that it's not been fully and equitably applied over all of our age groups. As part of a board-sanctioned national initiative to address equity gaps across all of our quality measures, what we have found is an opportunity in our young and middle-aged adult population. And as a result, our teams are now actively engaging and putting together plans and strategies to pull in our young adults in their healthcare journey. Anything from app-based care to asking preferences about telehealth visits, making sure that we are providing patient-centered care based on the preferences of this patient population to get them engaged, and making sure that we have equitable care and optimal care across all of our patient populations. And we are looking at this really, it's just the next chapter in our journey. And I'm very proud of our teams. I know this is for time constraints, I'm going to cut it off here, but I'm available for any questions or follow-up as part of the panel discussion.
Perfect. Thank you so much, Debra. Quite a rapid review of all the efforts that have gone into improving this work. So thank you. So we'll go to the panel, and there's so many directions we can take this conversation, because the paradigm of diabetes management, and not just the management, the science part of it, the diagnostics, really thinking about complications, has shifted significantly, and all of you have alluded to it or directly addressed it in many ways. One of the first things that I'll ask, and I'll go to Dr. Pothuloori first, and then Dr. Bajaj, and then Debra, is if there was one thing that you want our clinical teams to walk away knowing today about diabetes, whether it's management or complications, what is the top thing you want them to remember every time they think about diabetes and our patients? Dr. Pothuloori, I'll go to you first.
So that's an excellent question. I think the most important thing we need to know about diabetes is that it differs from person to person. And, we have all these recommendations for complications, but there is a human being, and their experience with their disease might differ from someone else with the same exact A1C. And so I always say that we should listen to our patients, listen about their journey, about their diseases, about their life, their socioeconomic issues, and provide what we call holistic and patient-centered care. That's the most important thing, in my opinion.
Well said. Dr. Bajaj, what's your take on this?
Yeah, I think, besides individualizing therapy, which Dr. Pothuloori spoke about, it's important to remember that in the United States, about 53% of the type 2 diabetes we see is associated with obesity. And so lifestyle modification, is the key to diabetes management. We were always targeting A1Cs in our patients, and that's important, but that's strongly linked to body weight. And weight reduction is really our target now, besides glucose control. So you got to look at the obesity aspect of it very carefully, target it with diet, exercise, lifestyle modification if you want to prevent the complications.
Okay, thank you for that. Debra, what's in your opinion the number one thing you want the teams to know?
Well, I'm going to wrap it all together. I think shared decision making. I think that, sitting down and finding out what matters to the patient so that we can help engage them in self-management and lifestyle modifications. As it's different, as Dr. Pothuloori mentioned, for every patient, but taking a moment to see what matters to that patient so that we can link them to the resources that are aligned with their own values and cultures, I think is very important part of this treatment plan.
Well said. Thanks. I think when I'm in my practice, right, so I do part-time internal medicine, primary care. One of the things that I struggle with the most, and I'll be the first one to raise my hand, is doing all of those things that you all mentioned, right? Is sort of taking a pause in my day, saying, who am I talking to? What's the most important thing to them? What are some barriers to getting them to the goal that they have? And I think that the management techniques, the diagnostic techniques that all of you have mentioned is part and parcel of that conversation to say, hey, this is not just about your sugars, it's really about how do we make you healthy overall? How do we protect your heart, your kidney, your liver now, and everything else, right? I know we are up against time, but I'll give one more question out to each of you, and I'll go in reverse order this time, which is, what is exciting to you? What is hopeful to you? Because this is a paradigm shift. Because for decades, we've been using insulin, insulin, insulin. That's your go-to mainstay for uncontrolled diabetes. What brings you hope? What excites you about where diabetes and overall health management of patients with diabetes is going? Debra, Dr. Bajaj, and Dr. Pothuloori to wrap it up.
Well, I think the effectiveness of the medications that we have and the accessibility of those, because when we started this, they were not accessible and they were not approved for all insurance plans. So to me, that has just been, the skies have opened and the sun is shining, that we have accessibility to these.
Fantastic. Dr. Bajaj, what about you?
Yeah, I think when I was a resident, all we had was NPH and regular insulin and sulfonylureas. And today you can see we have a plethora of medications. I think the advancement in the field of obesity management is really mind-boggling. We never thought we would get medications that could cause such dramatic weight loss. And these are only expanding on the horizon, and their accessibility, we've been fighting to improve it for all patients. I think that's a very big advancement in the field of diabetes.
Great. Thank you. Dr. Pothuloori?
Yeah, I mean, I would agree with all the answers that all the what the other panelists have said. Sorry. In my years, a lot of these drugs were out when I was training. I think one of the most exciting things is that there is greater attention to diabetes, not just to A1C, but to say, hey, let's sound an alarm here. That there are younger people getting diabetes, at younger age, getting type 2 diabetes. We need to really look at all these issues addressing lifestyle, diet, and also put more focus on education of our patients. And it's exciting that we're actually learning more about diabetes. I mean, we used to always say, well, BMI, 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 but now we're seeing that visceral fat is extremely important to look at, or body fat composition. How does a different type of fat affect inflammatory markers and complications in diabetes, looking at fatty liver disease. And, we didn't really look at these things as closely, or we didn't give it as much attention as we do now. But I think that it's exciting because we are really starting to get better understanding of the pathophysiological issues in diabetes, the complications. The technology is changing of continuous glucose monitors, changing behaviors. The treatments are getting updated. I think we have a bright future ahead. So,
thank you. I think those are all very, very, very good reasons to be very hopeful and to look to the future because we are moving in the direction. I guess I will wrap it up and saying we very purposefully picked this panel because what's giving me a lot of excitement and hope is the fact that CommonSpirit, being one of the largest healthcare systems in the United States, has the expertise right here within our grasp to really bring us to that next iteration of diabetes management. So really a big thank you from all of us to our panelists for joining us today because this is what it takes, that interdisciplinary excellent expertise to make things change for our patients and our communities. So thank you. And with that, we will wrap it up. I will make a plug for the next grand rounds, which are on March 21st, which will be delving into health-related social needs, assessments, and management, very much part and parcel of our conversation on management of metabolic diseases within our patient population. So please tune in and thank you again from all of us for joining.